أنا already on Zoom دلوقتي. So.
Good evening, Prof. Hafez. How are you?
Yes. Hello.
Hello.
Yes.
Am I audible? Prof, you can hear
Hello.
me?
Yes, I can hear you. Do you want me to start now?
Okay, yes, I can hear you. Welcome for the CME. I think we can start.
Okay.
Yeah, today we are
I'm
discussing advances in arthroplasty, especially the hip. And our guest speaker is
Yes.
Professor Mahmoud Hafez from Egypt. He's a professor of orthopedics with a very big experience in arthroplasty, both in knee and the hip. And today we chose a topic that he really likes. So welcome, and we can start off, Prof.
First, thank you so much for the invitation, and thanks for the large audience. And I hope that I'm going to meet the objectives and also what you're looking for to hear from me. And I would love also to have more time for questions, because questions and discussion, I think, is much more important than didactic talks. So let me just share with you first the screen. And then I'm happy to take questions in the middle if you want, or at the end, whatever the moderator would suggest. I hope you can see the screen now.
Yes, we can.
Okay. So this is my second talk to Kenyan Orthopedic Association. I think last year we did a talk on knee replacement. The audience were totally engaged and we had very good discussion at the end of the talk. So I hope we could have the same for hip replacement today. I know it is difficult to, when you have a large audience, to ask what do you want to hear or what you're looking for to hear from me today. And I would give the talk that I'm preparing, but I'm happy if there is anything that's not covered in this talk, we can cover it, from other presentations that I already have on hip replacement. So just in case, if you ask me, can we use this technology, for example, for a fused or ankylosed hip? Okay. In this case, I can give like a very quick presentation on any topic that could be more relevant to your practice. This is my disclosure. When we talk about advances in arthroplasty in general, and especially in hip replacement, we can divide this into many things. I mean, there is advances on the techniques and there is advances also in the material. I'm not focusing much on the material because the hip replacement that we use, you will be surprised to know that some hip replacement we're still using now are the invention of 1960s. Still cemented hip was isolationally, and then what came after that was Exeter is still in common use, especially in UK. I practice in UK, and cemented hip replacement is more common than uncemented. So with advances in the type of arthroplasty of the material and the type of implant with regards to fixation, with regards to bearing surfaces, we can also to talk about this in the middle. But I'm going to focus more on the things that you probably don't hear much in orthopedics and orthopedic conferences or from orthopedic surgeons, like personalized medicine, like computer orthopedic surgery, robotics, navigation, patient specific, like artificial intelligence, the theory and practice of all these, and then what is in the past, present, and future. And then the applications worldwide. Is these things which we hear about, is it just experimental? Is it a dream, or is it something happening in reality? We're going to talk about it. And also I'm going to talk about the applications in Egypt, and then the challenges in developing countries, especially like our countries in Africa. Here is just like an imaginative surgery for the hip that will be soon coming into practice, where you're having virtual reality and having, for example, an MRI image of the hip joint, while on the screen, the surgeon can see the images of the MRI and the image imposed on the patient anatomy. Okay, so that he can see things which he doesn't normally see when he's doing the conventional surgery. Okay, but I thought that before going into the depth of advances in arthroplasty, I'm sure there are some juniors here who wants just to know the basics. So I'm having just only very few slides on the basics, just to, you know, get everybody engaged in this talk. So you know that arthroplasty is not only done for arthritis. It is commonly done for fractured neck of femur when we think that the fracture is not going to heal or there is a risk of a vascular necrosis. And that's why we prefer to do arthroplasty to let the patient have only one operation and walk straight away. So with arthroplasty, hemiarthroplasty, we either use a monopolar or unipolar implants, which is less commonly used now, like Thompson and osteomore. And then there is a bipolar, which is much more common now. And these are the components of the bipolar, as you can see, that we commonly use nowadays. That one big advantage of the bipolar is not the double articulation and reducing the wear on acetabulum. It is actually the ability to convert the bipolar into a total hip replacement. Um, so after some time, patient will start to complain of pain in the acetabulum because of erosion, and then rather than having a monopolar implant that you have to remove completely, in this case, you can keep the stem and just change the head. Here is a hip arthritis, and this picture is just showing you the normal and the arthritic side just to see the differences. Um, with something like this, you need to do a total hip replacement because acetabulum here is damaged. And the basics of our hip replacement, what we do is we remove the head and neck, and then we have to ream the acetabular component in the pelvis, okay, and ream also the proximal femur in order to put a stem and then to put the components of the hip replacement. So commonly used, if you're using cemented, then you can use a cemented acetabular component, which could be a polyethylene. So in this case, polyethylene can stick to the cement, and then you can put it in the pelvis as a one component. On the stem side, usually there is a stem and there is a head, but the old Charlie was just like a monoblock where the head and the stem is one piece. Okay, less used now, more commonly used where you have a head and stem. And then the acetabular component, if it is uncemented, then you have to use uh, a metal pack and then a liner. And this liner could be um, polyethylene or could be ceramic. Commonly used now is a cross-linked polyethylene, and on the head side, we're using always like a copper chrome that could articulate with a polyethylene, or you can use a ceramic head that can articulate either with a ceramic liner or with a cross-linked polyethylene. I hope this is clear. This is like the anatomy of the hip prosthesis, what looks like, as you can see here, with a cemented socket, okay? As I mentioned, whether it is usually polyethylene, and then the uncemented one is the metal that could have osseointegration because it is coated with hydroxyapatite. And this is a stem, as you can see. There are parameters for the stem. You need to know the length, the diameter, and then the offset. We're not going to go to this because this is outside the scope of my talk. But just quickly to touch base on the basics, and also to show you some of the advances that happened a while ago, like 20 years ago, when hip resurfacing started and became very popular, and then later on, because of problems with certain companies and the manufacturing, some complications happened, and then now it's becoming much less used. I did, I don't say a lot, but I did hip resurfacing for patients who are still enjoying this procedure, and I wished if this procedure is still common and popular, but it's not, unfortunately. Okay, in this case, you're keeping the head. You don't remove the head or the neck. You only like shave the head, and then you put like an umbrella, as you can see here, with a short stem that stay in the neck, and then you put the component. One of the problem of hip resurfacing was the fracture of the neck of the femur, and then, as I mentioned, also material problem that caused something called alval or soft tissue reactions, and problems also of metal on metal, and the metal ions that can cause systemic manifestation. So these are, I would say, old advances in the last 2 decades or so. Also, in the last 2 decades, we started hearing about something called MIS, which is minimally invasive hip replacement. We used to do long scar and long incision, as you can see here for the hip, the one with a dotted in red here, as you can see how long it is. And some surgeon using the MIS, which is a short one, as you can see here in blue. One of the main problems happen with the MIS is the complications where the component are not well aligned. And to be honest with you, it is much, much more important to have a good alignment to get a good survival for the implant rather than having a cosmetic short scar. Having said that, I personally do some sort of MIS, but we call it mini incision, where it is something between that minimally invasive and also between the conventional. With the mini incision, could be around 10, 12 centimeter or so, but it gives good exposure without compromising the quality. One of the ideas that we use here is something called mobile window technique, where the incision, your incision, rather than having a fixed retractors that stay keeping the incision all the time fixed, by moving the incision proximally, distally, anteriorly, posteriorly, then you're getting more exposure. And also, I don't use special instrument, I just use regular instrumentation. And there are many advances also happen with regards to the approach. I'm sure you heard about the anterior approach. I'm sure you heard about superior approach and many other things that came with that. My advice to you is use whatever you're confident with and whatever you are familiar with to get the good results. At the end, the purpose is not to have anterior or posterior scar or incision. The purpose is to have a good aligned and good technique, complete aseptic procedure, so that to avoid complications and to give good function, good survival for your hip implant. I personally use the posterior and lateral, but I use more lateral now. I work between UK and Egypt, and it came to my surgery. Most of the surgeons are using posterior, which is very strange because when I left UK and went to North America, US and Canada, where I was working there, at the time, the North American, they were more to the posterior approach and UK was lateral. But now many of them are using posterior approach. Now, when we face with conditions like this, where you have screws in the acetabulum, or you have other things, things like this. Look at the patient here. I'm just giving an example for knee arthritis, which is more common than hip arthritis. I'm sure in Kenya, like in Egypt and many other African countries, where knee arthritis is more common, or if I say primary knee arthritis or primary arthritis in the knee is much more common than primary hip arthritis. Most of the hip arthritis happens um, in our countries are secondary. So they are not primary arthritis, but they are secondary to either failure of fixation of fracture neck of femur, pediatric hip diseases, AVN, many other conditions, which are here, osteoarthritis is secondary rather than a primary. But primary arthritis in the knees, which is very common, patient usually present late and present like this. You cannot have like a conventional, you need really advances in arthroplasty in order to deal with problems like this. Look at a problem like this. I mean, I've never seen a patient like this either in UK, US, or Canada, because, patients with problems that not sorted out at the time when there is like a DDH or neglected any pediatric head disease and end up with something like this, making life difficult. So why we having difficult cases, we having late presentations, we having patients who have also demand, like for example, squatting, sitting on the floor, if they have floor toilet, or their habits to sit on the floor. And with all these, and then we having less facilities and we don't have technology. So that's really not fair. So what you would expect? I mean, you would expect that outcome is not going to. So how can we make our outcome optimal with such difficult cases? Now we're talking about something called personalized medicine, okay? And this is different names of personalized medicine. What I meant here by personalized medicine, we're not just talking about dreams or something. No, it's actually personalized medicine is what we need in our countries, because we have problems not similar to the problems that is in Europe or North America or other developed countries. Simply, the patients are different, they present late, and as I mentioned, all these factors. So if we have different problems, if we have different circumstances and conditions, then we must have personalized solutions. We must have that personalized medicine. And we must have also personalized medicine that's cost effective, that is not expensive, that's something affordable and something applicable to our countries and our facilities. That is what we call patient-specific orthopedics. So patient-specific orthopedics, if you make a search, you will find a lot in dental, maxillofacial, probably neuro, some in musculoskeletal, and then orthopedics, as you can see here in Google, all these number of heads when you write that word patient-specific orthopedics, although not many talking about this. Here I'm going to focus about three things: robotics, navigation, and additive manufacturing, or 3D printing, which is used for patient-specific instrument and implants. I'm not going to talk much about robotics because it's not valid, or I wouldn't say valid, but it's not applicable, not cost effective in our countries. Okay. Again, navigation is less of use right now. I will focus more about that last one. This is a screenshot from a robotic conference that I participated in 2 years ago in London. All the other speakers that you see, none of them is orthopedics. I am the only one in orthopedics. All the others are different specialties: urology, general surgery, gynecology, neurosurgery, all other surgical specialties, where robotic surgery becoming very popular. And I was surprised because robotics started first in orthopedics. The first surgical specialty that documented using a robot was in 1992 in Clinical Orthopedic Journal. And this was about Robodoc, which is a robotic surgery It was experimental at the time in USA from California. But later on, orthopedic robotic struggled a lot because of the FDA and other things, and then other surgical specialties. You hear about hospitals now, even in Egypt. In Egypt here, there is more robots used in urology and other surgical specialties with tumors and others than is used in orthopedics. Here are example of orthopedic robots, and our orthopedic robots is different from surgical robots. In the surgical robot, you will be surprised to know that the surgeon is not scrubbed and is not sitting by the patient. It is sitting in a room just close to the operating room. It's like a console where he's working on the robot, okay, but the robot itself is doing the surgery. The robot, for example, is suturing the heart or part of the heart or manipulating or doing something, okay, while the surgeon is just like moving like a PlayStation, like a joystick, like the just using their hands and fingers to manipulate the hands of the robot, because the robot has a fine movement and less mistakes than the surgeons. While orthopedic robots is completely different. Here, orthopedic surgeon has to be scrubbed, has to be operating the robot, holding what we call end effector. End effector means the hand of the robot that is going to do something. For example, if you can see here, the robot is doing a milling or cutting of the bone. This is, for example, the distal femoral cut for a knee replacement. And as you can see, this some of the old robots. They are some more new robots now, which I'm going to show quickly. Why I have talking to you about robotics and other things, which I normally don't practice using them in Egypt. I do this because in the past, I worked in 3 places in UK where I had all my training, and I did a job where we were developing a robot, which I'm going to show you in the next slide. And then I went to US and Canada, where I was working in Pittsburgh with a group of engineers and an Institute of Computer-Assisted Orthopedic Surgery. A number of engineers here are more than number of surgeons. And they were, the inventors of hip navigation and other robotic surgery, which I'm going to show you. And also, I went to Canada and Toronto University, where I was using navigation. And all this experience came from there. So what I'm presenting to you now is something that I used rather than this is something that I searched on the internet and I prepared to talk about it. Okay, so here my first publication on robotics. I worked in robotics in 1998, and after 2 years, I managed to publish. This was the first report on preparing or manufacturing a robot for knee replacement. And this was a group of engineers from 3 universities in UK, Hull, Loughborough, and Dundee. And, unfortunately, this has not been used in practice. The one which is used in practice is the one I was working on in Pittsburgh. The one you see on the left side is a prototype, and the one on the right side is the real one, which is used by Smith and Nephew, and they changed its name now. Nephew, which is a handheld robot, where you hold the robot like holding a drill, and then the robot can make the cuts. And it was initially designed for unicompartmental and then progressed later on for other uses. Here is a navigation system. I wouldn't talk much about it, but navigation is just the GPS. Like when you go going to a place, you're going to home or visiting a friend, and then send you the location, and then you look at the map and you follow this instruction. This is exactly the same. So rather than having a satellite that is watching your car or guiding your car, here the satellite is inside the operating room, which is a camera looking at what we call here infrared diodes that's inserted on the femur and on the tibia, and that sends rays to the camera. So the camera can track if the knee is bent like 90 degrees or if the knee is inverse or valgus. All this information will be displayed on the screen. But in general, robotics and navigation, they have a lot of common drawbacks, as you can see here. At the bottom in blue shading, you can see all the problems with robotics, okay? I would stop here, and then maybe I can take some questions, because the next part of the talk is about a different technology. Please give me also feedback if I'm talking too fast, too slow, if I'm stating the obvious or telling you something your intelligence, but telling you that you're or I'm talking about something which is more complex or not relevant to your practice. Know this, and also I'll be happy to take some questions.
Thank you, Prof.
Yes.
I'm waiting to see some answer for the questions, but my first question is, I did not get the big difference between robotics and navigation. And the other question I
Robotics
have
and navigation.
Yes.
So also let me look at also at the chat at the same time. And there are some questions sent on the chat.
Yes.
So you want the difference between robotics and navigation? Very good question. Navigation, we call it passive, as compared to robotics, which is active. And passive and active, this is just like in the classification when we classify computer-assisted techniques and devices. That navigation is like an information system. So exactly when you are driving a car and having this sort of navigation or GPS, which is telling you where you go, and if you want to the wrong street, it will redirect you and say redirection, okay? But it does not drive your car. You are the driver. So this is navigation. Robotics is if you have a self-drive car or a car which is not driven by yourself, but you are sitting on a back seat, and either a robot or either the car is moving by itself. So in this case, it is using also navigation. So every robotic has a navigation. Okay. But it is here, it is active. So the role of the surgeon with robotics is more passive. So for example, if I'm doing a knee replacement with a robot, I could make the incision, let the robot do the operation. Maybe my assistant will be just watching, and I can go and have a coffee and come back, look at the end, everything is done. Okay, I just put the implant, close the wound, and that's it. Okay, so that's the difference.
Okay, thank you. Let's look at the chart. My question is the aim of the robot to remove the orthopedic surgeon from the OR?
Well, one day it will happen. I tell you why. When I went to this robotic conference in UK, and they asked me, what do you think will happen in orthopedics? Is it going to be replacing the surgeon and and I said, well, it could happen, because if you know that there are 1 million knee replacement done in US every year, okay, and that there is no number of surgeons enough. Like for example, in UK, the waiting list could be more than 1 year, and there isn't enough surgeons to do all these knees. Don't you think that if the government in UK found a robot that can do the operation cheaper than the surgeon, he will definitely go for it. Okay. So in this case, he could have just an assistant who can just like open the wound and close the wound, and probably there could be a robot later on to do that step too. So there is a possibility in future, like everything that happens in our practice, where a robot can do and could replace human, like in factories. You can see, like in the car industries. If you go to a car factories, you will find probably very few staff there. The robots is doing everything. Okay. So, but how long this is going to take, nobody knows.
Is a robotic a specialist? So there is a robotic for the knee, a robot for the hip. Do we have some which can do all the fractures, or what? Or the robot is limited?
Um, the robot for fractures specifically.
Is a robot a
I mean, for knee
specialist?
replacement, every robot has different software. So that you can, when you buy a robot, you can tell them, okay, I want a robot to do knee replacement only. And then later on, you say, okay, I want one to do a shoulder. Then they can add the software for a shoulder. They can add the software for a hip replacement, and you pay more. But let me tell you that lower limb is more prone to computer assisted techniques than upper limb. Okay, the technique that I'm going to talk about later on, that can be used for everything. But so far, robot is used for hip, knee, possibly shoulder, but not more, and tumors.
Okay, so the orthopedic surgeon is still safe. Don't worry.
Well, at least in Africa, we're going to be for long. The robot cannot compete here.
Okay. The other question I have is, what are the benefits of using a robot instead of an orthopedic surgeon? Are there better results?
Yes, good question. I mean, so far, the cost effectiveness of orthopedic robots has not like proven. Okay. Um, I go to Dubai. I see many hospitals they having a robot. Saudi Arabia, many countries in the Gulf, orthopedic robots. It's private practice. They get more patients, uh, propaganda and other things. Okay. In UK, they are a bit more conservative. There are some robots in certain places, mainly for running studies, but it is not something that's common. Okay. Um, it's simply because of cost effectiveness. The cost of a robot, orthopedic robot, is around $1 million.
Okay. Um, with the evidence given of the first use of robotics and orthopedics in the 90s, what has been the main interests to its slow progression compared to other specialties?
Yeah, good question. Is mainly for FDA because of the safety. Um, because of some of the orthopedic robots, experimentally, uh, there were some complications and problems. Okay, and that's why it did not progress as fast as other surgical robots, like prostate surgery, for example. It's very boring for a surgeon to remove that prostate. For a robot, anything that's boring and tedious and takes time, the robot will not complain. Okay. So if you can imagine also, I mean, knee replacement, if I'm having a very long waiting list and for a surgeon wants to like do 1,000 knee replacement per year, sure will be knackered by the end of the year. So definitely a robot could help in this case. So is there any other questions?
There are several questions on the chat. What are
All
some of
right.
the documented? You can
Let me look at.
Can you see the questions on the chat?
Yeah, I'm looking at it now. Sorry. Can you get
So
some
who gets?
while I'm looking at the others? Just the screen is not showing me.
Okay, let me read for you. Who
Maybe you
gets
can
sued?
select also the most important ones.
I can read. Who gets sued if there is a complication when a robot has been used to do the operation?
What's a complication rate?
Who gets sued
What's a
if there is
complication
a?
rate for a robot? Well, all the robots definitely had more complications. Okay. I mean, definitely. I mean, anything which is relying on technology and computer. Okay. It was press, which is less common now. You know, one of the problems, for example, for navigation, I say error in, error out, because navigation will ask the surgeon to um, make certain landmarks. For example, for a knee, where is the epicondylar axis? Where is that? Like, for example, for a hip, can you touch the rim of the acetabulum? Can you touch the fovea in acetabulum, for example? If the surgeon did not put right information, then in this case, the navigation might not be able to realize this. So if you put wrong data, then you will get a wrong guidance to you. So this is one of the complications. For navigation, you put pins, and also for robotics. So these pins, it has to be fixed in the bone well. So if a bone is osteoporotic, then the likelihood of this pen being moved, and then this will become less accurate.
Hello, there is a injectable still that I'm looking for. What over here? They're
Somebody asking about the duration of surgery. Robotics and navigation usually takes more time, but the technology I'm going to present is the opposite. It takes less time. So with that, for navigation, if somebody expert, it could take like maybe from 5 to 15 minutes more. Somebody not good with or familiar may take an hour or more. And probably same for robotics. You will require an assistant for navigation, and usually for navigation and robots, you will require somebody to operate them in the room. And that's why I put this as a common drawbacks for navigation and for robotics. Is there any other question that I didn't answer?
Who gets sued if there is a complication? I never got the answer to that.
At any time you can, move to conventional, so that you can do what we call it conversion from computer assisted to a conventional surgery. So if the robot, for example, if you don't trust it, or you feel that there is something going wrong or any complications, then in this case, you can drop it and just use your conventional techniques.
Something on the rate of infection, comparing the robot and the surgeon?
Yeah, good question. Also, the problem is that with robotics and navigation, you have a lot of equipment inside the operating room. And the robot, you cannot send the robot to the autoclave or sterilize it. So it is covered like, like when we cover image intensifier, okay? So in this case, if you cover it, then the possibility infection to higher probably than conventional. But on the other hand, um, less manipulation by a surgeon or assistant and having a sterilized end effector of the robot, then you may say that possibly will cause less infection. But knee replacement, for knee replacement, robotics and navigation is good because you don't go into the medullary canal. You calculate the axis, mechanical axis by the computer. So in this case, you don't go into medullary canal. And if you don't go to medullary canal, then the risk of infection is less. The bleeding is less. Operative time usually is less. Although navigation robotics takes longer time, but if you have a complex case of extra-articular deformity and using one of these technology, then definitely will be advantage.
There was a question of who gets sued when there's some complication.
Yeah, another question. Well, I mean, the companies, if there is any defect in the companies, if the companies didn't give you enough guidance, and then you do something that can cause complications, then the company can be sued. But in fact, most of the cases will be the surgeon. It is the surgeon who's responsible for this because the surgeon who's decided to use this technology, he is responsible because he should check everything before using this technology. And I think by the end, it is the surgeon's responsibility.
Does the robot require an assistant?
Sorry?
Does the robot require an assistant?
A robot would require technician at least to operate it, yes, because most of the nurses are less familiar with the robot. So unless they are using it routinely, in this case, the company or the technician will train the nurse, and it's not going to be the scrub nurse. It's going to be another nurse who is going to be operating the robot rather than a technician from the company.
Okay.
Okay.
Last
Some
time,
other questions we can carry on with the book.
pardon?
Okay. Is that
Okay.
okay? Mr. Corazzo, is that okay to continue? Or do you have any other questions?
So do the surgeons have to learn how to use the robotics, or it is just an IT person who does it? Or is a mix?
No, the surgeon has to be trained. There's actually no training, no use, because if you use something complex like this and you're not trained for it, then problems could happen. So definitely you need training as a surgeon in order to do this. And the training is not easy because the robot will require a few things to be done. As I mentioned, you have to, for a hip replacement, you have to insert a pen in the close to the trochanteric area in the femur and one pen in the iliac crest. So this you need to do it while you're preparing the robot. And then you need to take certain anatomical landmarks and things like this. So you need to be trained on how to use it and how to look at the screen of the robot and take the information and act on it, and also to operate the hand of the computer of the robotic hand. Okay.
Okay. You had something else to present?
Yes. Can I present now?
Okay. Let's go on.
Yeah. Okay. So let me share the screen again. Can you see the screen? Okay. So now you can see full screen.
I'm not seeing the screen.
I mentioned this is a select technology of robotics and navigation. There's something called patient specific in this. Okay, so in order to do that patient specific, we need to use tools, and these tools are the 3D printer. Here, as you can see, here's different types of 3D printer. This slide is engineering. You don't have to know about all these different types. But what I want to point out to you is that when I was working in UK and I did my MBA degree, 3D printer that I used in 2001, the cost for it was 500,000 sterling pounds, £500,000 sterling. This is a lot of money for Egypt, for example, here. Okay. Now, these printers now, the cost for it dropped like 1,000 times. So now it is like around £500 rather than £500,000. And with this reduction in the cost, made the things easier to use and more applicable. So what can we use with this 3D printer? Here I just give you some different examples. Definitely 3D printers are more used in dental and maxillofacial than in any other specialty, okay? And what you can see here is first is a model, and this could be used for education and also for surgery. For example, if you have a fracture in the spine or a fracture in the acetabulum and it's complex, or you want to do osteotomy or whatever, then having a print of the anatomy, like to show you a tumor, to show a fracture, then that can make you easy plan it, okay? And also the same for education, that you can print anything like this. So like a skeleton that is already in plastic now, right? So you can print pathology, abnormal anatomy, okay? So this is a model, what we call it, okay? And then you can make a guide, and this is the one I presented last year to you that I used commonly for knee replacement. So rather than having used all instruments, then you can use this guide. I will show you on another slide. And then you can print an implant. Implant here like special plate and screws, okay? Or like a cup. This is a cup for a hip replacement. And this cup for a hip replacement is like a double cup. If you have a large mega acetabulum with a big defect, and then you want to make something really patient specific, then these 3D printers can print this for you. And the last thing, which is much more advanced, is to print spare parts. You're manufacturing human spare parts. Like somebody has the tumor in the mandible, and then you can MRI the other half of the mandible or reverse it to make the right left, okay? And then you can print it from certain material or manufacture it from certain material using these 3D printers, and then it will be implanted in the body, okay? You can have a hemipelvis, like a child or a patient who has got a tumor in the right hemipelvis that required excision of the whole hemipelvis, including acetabulum, ischium, pubic ramus, and all that. Then you can manufacture a hemipelvis and implant it. And that is going to be biocompatible and sometimes also osteointegratable. It can integrate with the bone. Okay, so that's Prof. Here is things that's used commonly in neurosurgery. If somebody was had in the skull and he or had a tumor in the skull and ended up with a large effect, if it's a small defect, sometimes neurosurgeons leave it, okay? But if it's a large effect like this, then rather than having an artificial material, titanium or something, he can have a graft from a material that's going to be integrated with the bone and then going to be part of this bone. Okay, and that's used for 3D printing. Another thing that if you have a tumor, for example, a case where either infection in the whole femur, tumor, a problem that you need what's called total femoral replacement, where you replace the acetabulum, you replace the knee, you take the whole femur, and you just put this on soft tissue, then this could be done custom made based on the size and shape of this patient. Exactly. These things which are much more advanced than that, what's called bioprinting, where you can print tissues. I'm not going to talk too much about this because this is still experimental, but it happens. Okay. Like, for example, somebody lost his ear, either by trauma or a congenital abnormality, then you can MRI the other ear, reverse it, and then make a scaffold, and also you can bioprint the ear. Okay, it will be definitely easier if you are bioprinting like a one type of tissue, like a cartilage. But here you can have a cartilage and you can it. The artificial scan, which is or our artificial because it become natural, like the graft that you take from one part of the skin and then you put it on a defect. Here you can manufacture the skin. It's like a spare part now here, right? And this you can do it with these 3D printers as a bioprinting. In orthopedics, although we had the first stem cell application, which is a bone graft, because we are the first in all other surgical specialties or medical specialties where we use a graft to take part of the bone from iliac crest, put it in the tibia or anywhere else. Okay, that's considered to be part of a stem cell, isn't it? And but still, we cannot use artificial material. You could have a knee replacement, but you cannot have something in the middle of the femur, like what I'm showing here. Okay, this is still experimental. I can tell you, I helped one of my colleagues who was a oncologist last week to manufacture part of a proximal femur, which had a tumor, something similar to what you can see here, where it's something that can be implanted in the middle of the proximal femur to cover a large defect. Some surgeons, for example, who are using a laser or using limb reconstruction, they will say, okay, why do this? We can do a bone transport, and then we can cover a defect like this. But we don't, when you don't have bone, when you don't have when you have a tumor, and using, for example, a tumor implant, but you ended up with another defect because the tumor implant cannot cover everything, then in this case, you don't have any options apart from doing something like this. With the 3D printing also, it's commonly used for prosthesis, as you can see here, external prosthesis where you have an amputation, and then you can do something which is patient-specific. I mentioned already about this slide, and the cost dropped significantly. That makes 3D printing affordable. Okay. Here, the problems that we face here, for example, in our countries, is the lack of funding in order to advance and look for technologies that could be suitable for our problems. Okay. In the West, they are not sorting out our problems. They are sorting out their problems. So we need to have patient specific. We need to have personalized medicine, especially for Africa, because in Africa, we are less advanced than any other continents and any other places, unfortunately. Okay. So, like if you talk about North America, they are very close to North America. They can benefit from technology. In Asian countries, you have also close to other advanced technology. But in Africa, we are deprived from the benefits of the technology. I'm not sure how many African countries they have knee replacement kits in order to have knee replacement. I'm sure there are some countries where they don't have this, at least in all cities. Um, Many countries, for example, don't have even revision implant sets. So if you have a primary, there is a rule. Some places they will say, okay, I'm not going to take a primary implant if I don't have a revision implant to use in case of any failure. So if the basic things like this, like a knee replacement and a hip replacement, which has been there for the last, I would say, 40, 60 years, and then um, the technology become really very difficult for us to use. But with the help and connection with each other, we can help in establishing research and development to look at our problems and to look at solutions and also to publish about our problems. Otherwise, nobody will know about it. So I adopted the something here in Egypt where I do self-funding in order to progress and advance this technology. When I left North America, and at that time, I was using robot navigation and patient-specific, three big technologies that most of the surgeons usually are familiar with one of these, not the three of them. And I'm using them, and I know the theory and the practice. They were very surprised where somebody like me will go to Egypt. He's not going to use any of these technology, but I use them. I use them, and I will show you what we have done. This is a publication about the use of 3D printing since it came in Egypt. This, was published a long time ago, and we use a lot, by having networking. I mean, so it's used a lot, especially for knee replacement. Like when you have a revision knee replacement, you can't imagine the number of trays and number of instruments. It's like a 500 pieces of instruments. A number of implants. It's like 150 boxes coming. And that's definitely can cause a lot of problems like infection and long operative time. And also you'll be surprised by intraoperative, unforeseen circumstances that could happen. But having a technology where you can plan everything and drop all this instrumentation system and get something like this, like 2 blocks to do your knee replacement rather than all these instruments and avoiding the entry of the medullary canal, reducing the fat implants, then that's definitely a big advantage. And that's what we call patient-specific templating for knee replacement. Or you hear this in the either media or in your search, what's called PSI, custom-made cutting guides, which is used for knee replacement. Definitely, if you look at the literature, you will see that this is not cost effective because in Europe and North America, they use it only for straightforward knee replacement. That's why it's not to be effective. But here we have very complex cases that needs planning and needs doing. I just to give this example knees, but I will focus on hips. But I'm just showing you how I'm using these guides to help me doing complex cases like extra-articular deformity, any complex cases that's difficult. We published a study, what's called hospital-based, where you can have in your hospital, you can establish a system that can help you by having this technology in your hospital so that you don't need to buy a robot. And that's not expensive, something that's really very affordable to any hospital. And I'm very happy to do this in any country in Africa, because that's going to be very useful to you. I will show you the things that I did in Egypt. I do knee replacement almost routinely using these PST technology with the 3D printing. Hip surgery, I use it for complex arthroplasty, not for every case. I help friends to do shoulder surgery. I do it for osteotomy. I also help colleagues to do spine because I don't do spine and shoulder. Okay, so we have guides for pedicle screws, especially for complex scoliosis. Some spinal surgeons are very confident. They say, oh, we do pedicle screw blindly. I don't need guide for this. But believe me, there is a missing rate. Amenosous scoliosis, definitely high missing rate. You can use it for malunion, knee replacement, which is experimental. So this is just a picture to show you the different guides that we use. This is for total knee replacement. This is for unicompartmental, which is really demanding surgery, very difficult. This is for osteotomy. This is for shoulder, and this is for hip. And then we use it also for tumor. We use a spacer, patient-specific. The problem with the current spacer that you use for infection, they are not patient-specific. They all have gentamicin. How many patients who, the cultural sensitivity are sensitive to gentamicin? So why are you putting an antibiotic which is not sensitive, which is not going to work? That's going to be a foreign body. But you need to have a patient specific according to the side of the defect that you have, side of a snabulum, side of the femur with a long stem, short stem, or whatever, and also have the specific antibiotic in it. And that's what we do. Also, you do this for the spine, as I mentioned, for pedicle screws. Here is the complex cases of a hip. A patient who had fracture and the snabulum had plating, had infection, and then they removed the neck, the neck and head of the femur, and they put a spacer. The cement spacer first didn't work. Patient came to me after having all these operations with pus coming out from the hip. So I put a hip spacer, patient specific here, and then we killed the infection. And after we killed the infection, then we planned the defect was too big, and it's something called pelvic instable discontinuity. So with a pelvic discontinuity, it means that the pelvis, as you can see here, okay, is discontinued. This is just a model showing that the pelvis is just like separated. The ilium on top and then the pubis and ischium are separate fragment, okay? So that's called pelvic discontinuity. And then most of the pelvic discontinuity, the medial wall is usually gone, okay? As in fact, medial wall, you can see it here. See the spacer going on, okay? Inside the pelvis. What this means? It means that acetabulum is medial wall is not there, okay? What you can see here is this yellow part here inside the pelvis. This was a technique that I used and I published it in GBGS American, what I call it Mexican hat, similar to the Charlie Mexican hat, where I make a small cement spacer to cover the medial wall of the acetabulum, and it has like a hat that goes inside the pelvis. And I usually put an antibiotic in it, as a vancomycin or something that patient is sensitive to. Okay, and this has two benefits. First is to kill the infection that went already inside the soft tissue of the pelvis, and the second, it prevent the spacer from penetrating the pelvis. So I use this with that condition of pelvic discontinuity. And then we designed that, as you can see here, a patient-specific custom-made implants that it's used for this such case. And it has a guide. So these guides, as you can see here, has many holes to insert the screws in pubis, in ischium, and in ilium. You have to insert screws. Most of the time, you insert the screws in the cup superiorly. But in a case like this, rather than using a plate, anterior plating and infection at the head. Okay, so rather than having this, you just only have one operation where you have this custom-made cup, what's called triphalangeal, with screws that fix in ilium, pubis and ischium with a guide. So that in this case, you don't have to worry about sciatic nerve or anything else. You're not going to miss the bone. These guides, you put it on the true cup at the end, okay? And then you put the screws, I would say blindly here, because everything is already planned. So in a case like this is inside the operating room when the cup was inserted already, and this guide is put. You don't have to measure the screws so that you don't waste time. So for example, for a case like this, there were 17 screws to be inserted. I ended up by inserting only 16. So I missed only one screw, which is not, I found that it is unnecessary to put that too many screws in the ilium. There was a very good fixation, so I just skipped one. But I put all the other screws in the cup and also ischium, ilium, and pubis. And this is a CT scan to show you the position of all these screws, which is almost exactly like the preoperative planning. Somebody will tell me, oh my God, all these screws. I would say, yes, there's a good fixation. And this is a pelvic discontinuity. This is a very complex condition. And rather than having two plates and screws and having another screws for the cup, the total number of screws could be even more than that. Okay. But here, this is a good fixation is all well planned. These screws, you wouldn't believe it, but it took probably 20 minutes or less to insert all these screws because the size of the screws, the diameter already predetermined, they are already opened and they are numbered. So I would say screw number 1, 2, 3, 5, and so on. And they get you the length. You don't measure it. And is everything done as planned. And this is, as I said, published in GBS after 5 years. So there is a message here. I mean, I have examples of so many cases to tell you about using this technology for the hip, but this just summarizes some of it. But I use it a lot also for infection. So my message to you is that patient specific as compared to robotics and navigation and other things is an application is the robot and the navigation is an application looking for sorry, let me rephrase this. The patient-specific technology that we're using is an application or a technology, is a need looking for a technology. So I had problems here when I came to Egypt. I found that these problems need a certain technology. I used navigation when I started and I came here, and this didn't help me much. And I found that the patient-specific templating and also the 3D printing is a technology I'm looking for. But what they do in developed countries is that they have a technology like a robot, okay? And they want to use this technology, which was very good, like in car industry. They wanted to use it in surgery, okay? So it may work in one part, but doesn't have to, but it's not going to work in everything, okay? Because it is just it is the other way around, rather than a need that looking for technology. Here you're having a technology that looking for a clinical application. I hope you got this message, and I'm happy to take any questions from you. Thank you so much.
Thank you very much, Prof, for that information. Can we have some questions? My first question
Can
is,
you hear me well?
yeah, we can hear you. What is the cost? What's the cost of this application? In terms
Yeah,
of
the guides are not costly. The guides are not costly at all, okay, compared to the cost of the implant. For example, if you're using a revision knee replacement, okay, the revision knee replacement or a hinged knee, for example, is too expensive. So having a planning or guide that tells you the sizes that you're going to use, that tells you the best implant, best company, that tells you how to make the cuts and avoid going to medullary canal, especially for primary needs, and also avoid a large number of instruments and all these implant stock that comes to the operating room. You can only have only the sizes that you're going to use. So by having this, definitely is a big advantage. And the cost of it could be less than like a 1 in 100 to the cost of the implant. But having a custom-made implant, this is very costly. Okay, the one that I showed you for the pelvic discontinuity with a triumphalangeal cup, that's expensive because you are manufacturing something specific for patients. But I can tell you for Africa, there are countries where you don't have, for example, if you go to a country in Africa where you don't have hinged knee, for example, or you don't have a revision knee implant or a revision hip implant. So in order to get the instruments for that implant and the implant itself, it's impossible. Okay. So in this case, having this technology and having the custom made, the cost of it could be comparable to the cost of the on-shelf implants, like a hinged or a revision hip implant. You got my point?
yeah.
So I'm looking here at questions again to see if there is any questions. There are questions about the robot, but is there any questions about the patient specific or the 3D printing, which I see that it is more suitable for our conditions because the cost is less. You know, like a guide for a revision knee implant, for example, could be just like a few $100 at a time when the implant itself is several thousands.
What materials are you using for the guides?
I use a guide for knee replacement routinely because I do bilateral in 95% of my patients. Patients usually refer to me for bilateral. Patients come asking for bilateral. So for bilateral, rather than going to the medullary canal and getting a risk of fat embolism that can kill the patient, then in this case, we use it routinely, and it saves money, time, less complications, good recovery, and all that sort of things. Especially patients come with, as I showed you, with like a bilateral varus, which is an flexion deformity. If you correct one leg and the other leg is short, deformed with varus and flexion deformity, patient is not happy. He will say, one leg is longer, you made my leg longer, I can't walk properly. And then in this case, when I do the bilateral, it's good. But if you do bilateral and you go inside the medullary canal and a femur and a tibia, especially if you're putting a tibial stem, then you're killing your patient if you're doing it conventional. So my advice, never do bilateral knee replacement using conventional instrument, especially when you consider putting a stem, either on one leg or two. In this case, use either navigation or use patient specific.
How did you start the program in Egypt, and how challenging was it? How did you manage the first case? When it was a new technology?
How I did the first case?
How did you start off? How did you start getting the guides? How did you start getting the DD printers? How did you start getting someone to do the implant for you?
Yes. Now, implants is a different technology from the guide, okay? So the guide is much simpler. The guide can be done in few days, okay? I can show you, maybe I can show you on screen here, where it tells you the steps. So this one tells you the steps. Can you see this screen? Can you see the screen?
Not yet. I can only see you.
Yeah, that's a patient-specific template for knee replacement. So if you look, I'm not sure if you can see the arrow. Can you see my arrow? At the top left, okay? The first thing is a preoperative planning. So you do a CT scan. So in order to use this technology, one of the drawbacks of using this technology is that you have to do an image before, either CT or MRI. You know, somebody for a spine will say, oh, no worries. Every one of our patients has got CT or MRI, okay? And then, for example, if you say complex hip, you will say, yes, we do CT scan. Okay, if you have a complex knee, probably you may do CT scan. But here, for a patient-specific template, you have to do it. And get the CT scan images, put it inside a software. And the software will do the planning for you. So first of all, we'll select, it has the implant. So that software, for example, in Egypt, I used this technique for 9 different implants. So I get the implant. Either I select the implant or I can see the differences between different implants and find, for example, that specific company or specific implant is the best for my case, especially for sizing, because the implant sizes are different in every company. One of the problems we have in Egypt right now is there are some sizes probably could be missing for implants because of problem with importing the implants. In this case, the technology here can tell you the sizing of the knee
Prof,
replacement that you want to use
we can't see the screen.
beforehand. I'm
Prof,
sorry?
we can't see the screen. We can't see
You
the
cannot?
screen. We cannot see the screen.
Oh, I'm sorry. Oh, give me a second. My apology. Can you see it now?
Not yet. Yes.
Okay. And can you see the arrow? Maybe you cannot see the arrow. Okay, it's at the top left. You can see what we call preoperative planning. So you do a CT scan, and then you plan the whole procedure. Okay, so the surgeon himself can do the planning. It takes about 15 minutes, or maybe an assistant. Okay, and it is simple. You look at the computer screen. The CT scan is uploaded, and then you're having the different implants. So you will see a screen to tell you which implant you want to use. Okay.
Okay.
And also it asks you for certain landmark, like point to the epicondylar medial epicondylar eminence, lateral epicondylar eminence, things like this. Okay, simple questions, and then all the planning is done for you, and it shows you the implant position on the bone. And then you can see the size and say, okay, this is a big size for a tibia. I want to see a small size. Just right click, and then select smaller size and see the difference in a few seconds. As you can see, the green part here is a polyethylene. The polyethylene is something really difficult to predict the size. Okay, but when we do the planning, we do it based on minimal bone cut, so that we do minimal bone cut, so that we preserve bone, so that we can use a polyethylene of size 10, for example. But sometimes, because of that laxity, we use 12, but at least you're not going to use any sizes larger than 4. Very, very unusual. But when you do knee replacement, there are certain tricks that even the expert surgeons could do mistakes and make a tibial cut, and then they found that using a polyethylene that is more than 17 or bigger. And then the knee will end up with unstable knee that may require revision. With using the planning here, you make sure that you're doing the cut properly. Also, you're not going to go inside the medullary canal because the planning is completely done for you. The software will automatically, after if you are satisfied with the planning, you say okay, and then the software will design a cutting guide, cutting block. This is like a 5-in-1 cutting block that make all the 5 cuts for the femur, and this one make the cut for the tibia, the one cut in the tibia and the stem and the keel. So when you position this guide on the bone, this is the most critical step. When you position it in a way so that it is a surface matching. It goes only into one position because it has like legs that sit on the bone. And when all the legs are sitting on the bone, this tells you that this is the right position. Then you fix it by pens, and then you make all the cuts. And then this is considered to be like a one guide replacing the 300 pieces of instrumentation that you normally use for knee replacement. And you do the same for a tibia, and that's it. Your knee replacement, the bone cuts could take less than 15 minutes. So in addition to incision, closure, exposure, cement time, and insertion of implant, then the whole procedure definitely much less time. I'm sorry, I'm showing you a knee. I don't have like a slide here similar for the hip, but for the hip you can use it for primary hip to tell you exactly where you put the screws. Okay, but it is more useful for complex hip, similar to the one I showed you. Is this clear?
Yes. There are. Can you tell us?
I can't
Can
see
you tell
the
us?
chat, so if you have questions on the chat, just tell me, and I'm happy to answer any questions from the chat.
Can you tell us what software is used when doing the planning?
This is a company called Surgeonovi from UK, which is actually using my patents. I have 21 patents in this technology. Hips, knees, spine, shoulder, as I mentioned to you.
Okay. How many African countries are using this?
I'm sorry?
How many other African countries are
Hello?
using the? How many African countries are using this apart from Egypt?
Yes, well, actually, in Nigeria, okay. Mainly, I didn't have any experience with Kenya, but went to Nigeria. I taught some surgeons there two experienced surgeons in two different cities. Okay, I went to other countries in India, and I did life surgery in New Delhi. I did life surgery in Ahmedabad with one time in All India Institute of Medical Sciences, which is one of the biggest medical colleges. I did in Bangladesh, I did in Indonesia, did in Bangladesh, in Jordan, many other countries. I'll be more than happy if you have a complex case in knee replacement or revision or hip, and then we can use this technology. Either we can help you get yourself happy to come and help any soldiers. So I'm happy to host any soldiers who could come to Egypt and to see this technology. I get fellows from different places. I had many fellows, especially from India. Quite a few came also from um, Indonesia, sorry, from other Asian countries, and also many come from Arab countries.
Good. Thank you very much, Prof, for the.
Thank you so much for the invitation. I'll be more than happy to. I mean, you have my email, and you can give it to colleagues, and I'm be more than happy to help in training or planning. We can even plan cases for you, and do it for you for free if you want, if you have any complex cases.
There are many complex cases, very challenging, and this particular piece of knowledge is critical for us. So thank you very much,
Thank you.
and I thank everyone for attending.
Thank you.
Thank you very much, and a good night.
Thank you.
جلسة إلكترونية بين قاضي ومحامي الميوت.